These two topics are like, if you like to dance, then you will understand this topic within 1 minute. Because fibrillation is like a marriage dance. Means especially when that barat is going, right? So everyone dances in their own tune, right? There are no footsteps. There are no steps, nothing. It is freestyle dance. While when it comes to flutter, so that flutter is like figure skating. That's the difference between both of them. Now, when you'll see it in ECG, a Nagin dance, exactly. Means marriage dance, Nagin dance. This is good. I'll write it. And you know, maje ki baat, everyone will be doing this Nagin dance in their own style. Actually, it happens in fibrillation. It happens exactly the same. So, yeah, let's start. So that's the topic for today. Nagin dance versus figure skating. So some of the things which we have already talked about. One was atrial flutter. So you know the rate, right? Atrial flutter is when it is between 250 to 350. And when it comes to fibrillation, so fibrillation is at an extremely high pace. That is more than 350. Right? Can go to 400, can go to 500. And will heart be able to beat at that rate? No. Actually, heart would be beating, right? But there won't be any output. So let's start with the dangerous thing first, because it is very tricky to manage the fibrillation. So that's why this would be our agenda. We'll start with the basics, right? We'll start with the basics, and immediately we'll see the ECG first, so that you know that what is happening. After that, if you have to really treat this patient, so what should be the pattern? Now, this pattern, which is like 3-step pattern, I totally agree that at this point of time, you won't be knowing that what are the anticoagulants, you won't be knowing that which are the calcium channel blockers, or what are the types of type 1, type 2, type 3, type 4 type of anti-arrhythmic drugs. No need, nahi chahiye, right? If I just say that anticoagulant, right? Anticoagulant. Coagulation is a process by which the blood is clotted. That is the process of coagulation. So it is not a big rocket science to understand that this is anticoagulant. It means it won't let the blood clot, right? So that's it. That's it. Blood clot will not be formed. So that is pretty easy, right? When I say that there would be a drug which will be stimulating parasympathetic system, right? Parasympathetic system. Now, with so much of discussion, you know that parasympathetic system is for rest and digest, right? Aram, relax. There is no tension, no stress, no hurry. So, stimulating parasympathetic system means what it will do to SA node? It will slow down, right? It will slow down the SA node, right? Which nerve? Apni all-time great, 10th cranial nerve, vagus, right? So, if we just say that we'll be using a parasympathomimetic. Mimetic means it will mimic, it will say, yes, I'll be supporting parasympathetic system. So that will lead to decrease in the heart rate. That is what is needed, because we are going over 350, right? So our today's discussion will be going with this pattern. Now, when we'll be discussing same topic in second Mbbs, so at that point we'll be going into the depth, that whether we have to go for apixaban, or whether we'll be using verapamil, or we'll be using diltiazem, because at that point you'll be knowing the classifications. You'll be knowing about all the anti-arrhythmic drugs. You'll be knowing about anticoagulant drugs. You'll be knowing about the entire pathway of the coagulation, right? Direct, indirect, you'll be knowing all the pathways. So that will make much better sense. But because you have made the base, so it will make things more clear. Now, as you will proceed further, right, so you will start learning that how to do the cardioversion. That means that electric shock therapy and how to use that. I'll be showing you one of the very good instrument. But even when you go to any of the clinic, even when you say in your life, in the patient, that is, they are giving that electric shock. So how that ECG is making the difference, even knowing that much is sufficient at this stage, right? So this will be the pattern. Sorry, this will be the pattern, and then we'll see that what can be the complications. So this is how we'll go in. Because we are learning in atrial fibrillation first, a complex thing first. Learning flutter will be so easy. And then, as the time permits, few minutes will be for what would be the surgical correction, and that is super interesting. This is where you will get a feel that things are way beyond our normal discussions of the ECG, etc. Right? So this is how we'll proceed. So let's start with the atrial fibrillation. Atrial fibrillation. So because atrial fibrillation is like that nagging dance, everyone will be dancing in their own way. So that's why when you take the pulse will be, this is the key word, irregular pulse. Why should that occur? Because if this is occurring, this is a finding by you. Patient won't be measuring his pulse or her pulse and then coming to you that I'm having this type of pulse. No. Patient won't say. Right? Patient will come up with. So this would be a sign. Right? Sign means what you elicit, what a doctor elicits. And symptom is what patient tells. Patient will tell, right? And that is what is called as the palpitation. Palpitations means when patient feels, yes, his heart is beating. Niket, we are talking about atrial fibrillation and atrial flutter. That is the topic for today. No worries, I understand. Right? This is the topic for today, atrial fibrillation and atrial flutter. And in case if you are into dancing, या कभी शादी में नाचे हो, literally the result just अभी ये भी मिला कि this is like nagging dance. So atrial fibrillation is like nagging dance, and atrial flutter, which we'll be discussing after about 45 minutes, that is like a figure skating, a very systematic, very sophisticated thing. Right? So coming back to this is fibrillation. Fibrillation is more than 350 beats per minute. Right? Heart is going at that pace. And we were just discussing about that what would be the pattern of our today's discussion, basics, and then we'll be going for the ECG. Right? Just now you'll be watching the ECG. We'll be learning about the treatment pattern, how such patients should be handled, and we'll talk about some of the complications, and we'll also be talking about some of the surgical corrections, how it is done, right? Because it is super interesting. So in atrial fibrillation, irregular pulse. Right? We'll discuss about this in a minute. But when it comes to patient, clinical symptoms means patient tells. He tells that my heart is beating, right? Palpitations. Because normally right now you won't be knowing, even if you close your eyes, you won't be knowing that heart is beating. Right? But when you start knowing it, when the patient starts knowing that yes, heart is beating, that is called as palpitation. Then fatigue. Patient feels very much tired. And the dyspnea, breathlessness. Now from this much discussion, right from the beginning till today, whatever we have discussed, at least we understand that when there is dyspnea, that means decreased oxygen. Oxygen is coming less, right? Fatigue, again, nutritions, they are not reaching to all the tissues. Oxygen is not reaching, tissues are also. So in other words, less blood is going, right? And then suddenly the sensitivity increases, so that's why a person starts feeling that his heart is beating. Very easy, simple reason. Here it is, that our heart. When the atria is beating at such a powerful pace, right, at 350, then do you really think that heart will be beating like this? Because 350 means what? If you make it 6, it is like almost 6 times per second. 6 times per second. Consider systole, diastole, this, that, everything. 6 times means this atria is beating at such way beyond tachycardia, way beyond. We are talking about 120, 130. No, we are talking way beyond. So this means that now the atria, when it is fibrillating, it is going at such high pace, the cardiac output decreases. Because at such high pace, it won't be able to contract. If it is not contracting, to the amount of blood which is to be pushed into the ventricles, so that from here it can be really pushed to rest of the body, that is decreased. This means preload decreases. Correct? This is left ventricle. Gun is not loaded. Right? This gun had the cartridge had got capacity to have 8 bullets. Only 1 bullet was loaded, and then it has to fire. So only 1 bullet got fired. Right? Preload is decreased. So when preload is decreased, that means instead of this much, only some blood is trickling. Obviously, less blood, fatigue. Less blood, dyspnea, breathlessness, because less oxygen. Right? So this is a very simple why these things occur. Let's see the ECG. Now we see the ECG with respect to normal ECG. Now see, this is a normal. This is a normal ECG, right? These conditions, say atrial fibrillation and atrial flutter, they are like split second. You can find it very easily. See how beautifully P, Q, R, S, T. And that is constantly following. Look at this. This is atrial fibrillation. No pattern. No pattern. Completely irregular. And this is technically called as the fibrillatory wave. But then why this QRS complex is going? Think it like, now we slow down the whole process at a very extremely low level. See what happens. Because another thing which you must have marked is, see the distance. See the distance. Again, a variable distance. Say for example, this distance. Right? They all are variable, and this distance, it is so big. I mean, there is no pattern. There is no pattern, right? All QRS complexes, they are coming in their own way. Now, this is what really happens. Think of, this is SA node, that is AV node. SA node is firing, right? Continuous SA node is firing. In other words, there are multiple impulses which are going, they are occurring at a rate of 350, and they are trying to stimulate AV node. One signal comes, AV node is stimulated, it sends the signal to the ventricles, QRS complex is formed. Let's say we start our journey from here, right? But now AV node needs some time because there is a refractory period. During that period, even any of the strong signal comes, AV node will keep his eyes closed. It will not work, right? So then constantly the signals, they are coming. And then as it comes out of the refractory, a signal has come and it will respond. So here is another one. Right? But again, by the time it come out from the refractory phase, this time it got some breathing time. This time it came much faster. So because they are randomly generated signals into the atria, so that's why there are randomly generated QRS complexes. And these QRS complexes are those complexes which has come out of the refractory phase of AV node. Because constantly it is firing, so AV node lets one pulse go, and then there is a phase, right, which is called as refractory phase, contracted, and then once again the resting membrane potential, it comes to threshold potential, and then it goes. Needs some time. So because of the refractory phase, this is the key question or the key word. Because of the refractory phase of the AV node, the waves QRS are, so QRS complexes are those waves which have escaped and they have reached. So that's why atria is beating at a much higher pace, because this every irregular wave, that is the atrial contraction, while QRS is a ventricular contraction. Right? So this part is clear. Watch one more thing. This is a full-fledged 12-lead ECG. Right? Just watch. First thing which you'll find in this is, first thing which you'll find in every lead, where is P wave? Right? See, this is lead 1, lead 2, lead 3, right? Lead 3. This is AVR, AVL, AVF, V1, V2, V3, V4, V5, V6, and we have got this V1, this is V1, this is lead 2, and this is V5. These are the rhythm strips. Right? These are the rhythm strips, because we wanted to see and calculate certain things. So that's why the rhythm strips were taken. So see this, pick up any one. Right? QRS complexes are okay. QRS complexes are okay, but P wave, right? And watch this segment, completely irregular. Watch this segment. Right? Otherwise, the ECGs, they are so disciplined. Na, kitna badhiya. It goes like this, right? While this is going like this, right? See the between the QRS complexes, completely irregular. If I really zoom it, you will appreciate it. See how irregular. Now there is, and you look at it into any of the lead, right? All the leads completely wavy, right? This is when we say that there is absent P wave, right? Absent P wave, and second, it is totally irregular QRS. You might not be able to see this thing sometimes when segment is just this small. That's why the rhythm strip. That's what the, see here. See the distance. This distance. This distance. Long one. So short. Again, medium. This short. Long. No pattern. No pattern. Correct? So this is classical of atrial fibrillation. Atrial fib, also lovingly called as the AFib. It's called as the AFib. So sometimes when it is written AFib, AFib means atrial fibrillation. Right? Have a look at one more ECG. This is also full 12 lead. And in this case, the heart rate is still more, right? It is extremely high heart rate, and you'll be able to decipher it within seconds. That just calculate this and we'll come to it. Right? Because it is just 1.5, right? Just 1.5 wave squares. So divide 300 by 1.5, right? So almost rate of 200. Things are moving at the speed of 200, right? Pretty high heart rate. Okay. Now, there is also VFib just 100. Definitely. And that is when what we'll be discussing next time. And there is it is called as the same ventricular tachycardia, but there the name is, it is what is called as the preventricular, premature ventricular beat. Right? It is called as the premature ventricular beat. One of the killer. That's why I've kept it, because next time I'm planning to take myocardial infarction, heart attack with premature ventricular beat. So we have discussed the heart failure previously also, right? But next time we'll be discussing it in light of when you have known so many things, right? And after that, I'll be putting those practice ECGs in which I'll be incorporating all these ECGs. Okay, so that's the thing. Right now, let's come back to this atrial fibrillation or AFib. So here also we have got one rhythm strip, right? This is the rhythm strip of lead 2, and this is lead 1, lead 2, lead 3. This is 3. This is AVR, AVL, AVF, and V1, V2, V3, V4, V5, V6, right over here. This would be the pattern which always remains like this. Again, we try to see where is the P wave. There is no P wave. But it looks like that, isn't this a P wave? No, it is not a P wave. It is T wave, right? T wave. The location of P wave should be this. Let's zoom. Right? That should be the thing. This one, it is a T wave. Right? P wave should be here. It is absent. So all these big spikes, and when we are going for the chest leads, right, depending upon what's the heart situation, right, you are getting all these. These are the T waves, but there is no proper P wave, right? See, even in rhythm strip. So practically it goes like this: is the QRS complex and T wave. QRS complex, T wave, and in between completely irregular pattern, right? Sometimes, and the distance between both of them. See the distance. This distance highly variable, right? If you really calculate, so this is almost 2 big squares. This is like almost 1.75 square. This is almost 2. This is much less than 2. This is just 1.5 square, right? See, over here, such big one, and this is this much, right? Such big variation. So there is no pattern. This means in A, P wave will be absent. P wave will be absent because, now we'll be discussing it, because it is fluttering. P wave form, what was the P wave formation? P wave was when beautifully the impulse goes from SA node, right? Bachmann's bundle, it goes, and it goes into the musculature of atria. So then it contracts because signal goes everywhere. So that's why right atrium, left atrium, and gracefully they form this P wave. Now, so they are not even, the proper signal is, right? It is just fibrillating. It is going at such a high pace, and that's why this irregular pattern. This proper P wave formation will not be there because atria are not contracting that properly. Right? So see, this is the thing. The baseline pattern is totally disturbed. So why should this strange phenomena occur? Coming back to same heart. So this is the left atrium. Right? That's the SA node. Here is the AV node, and then the whole process goes. Right? What really happens that from SA node to AV node things go, but there is development of, it is what is called as the development of multiple foci. These are the spots. These are the spots. They are classically called as multiple foci. Focus means one spot. Foci means many of them. Right? So these are the multiple foci in right atrium and or left atrium. Sometimes it is in both, sometimes only in one. And all of them fire. All of them fire randomly because they are every foci, every spot is sending a signal by itself. Right? It is not caring about anyone else. So it is sending a signal by itself. So this is what is called as the multiple foci. Now they are firing. Right? Those who have reached AV node, and AV node responded. So signal went further. So that would generate QRS complex. Right? Because systems are good from that point beyond. From here to everything is fine, right? Bundle of is this, the right bundle, left bundle, Purkinje, all are good. So yes, they will contract. What about others? Few of the signals, they were into refractory phase. Refractory phase. So those fired at the refractory phase, they were not allowed. So that's why there won't be any QRS complex in such case. So this is the reason that we have got such irregular waves, because all these waves, they are nothing but from somewhere, some foci is firing. So all those things, they are seen as an irregular wave. And then there is QRS complex. So it is that successful pulse which was able to reach to AV node, and it passed on to the ventricle, and it created this QRS complex, right? Otherwise, all these, they did Hawaii fire, right? Nothing happened. Right? So this is what is how it occurs. And so this is multiple foci. That is the first point. And the second one, why this is irregularly irregular, that is because of the random depolarization. Random depolarization. Now in this case, when it occurs, when this occurs, we need to think, whenever you come across paroxysmal, right, you'll come across this word very frequently. Paroxysmal. Paroxysmal means it comes and goes. Right? It comes and goes. And when it goes, so it will come back to this sinus rhythm. So once again, the normal P wave starts appearing and everything is fine, life is good. So that is called as paroxysm. In some cases, it is called as persistent. So when is paroxysmal? Paroxysmal is where sometimes it happens for a few hours. Maybe extreme shock, maybe extreme pain, maybe extremely dukhi. Yeah, 100-500 600 crore ki lottery lag gayi, extremely happy, right? And sometimes in this show in movie, right? So that is like this paroxysm. Right? Then comes that persistent, which lasts for days. It lasts for days. And in such case, you need to go for what's called as the cardioversion. You need to give them the shock. Cardioversion. There are drugs also available, but their drugs, they have got so much of toxicity. That's why this is much safer. You need to give anesthesia to the patient because that 20,000 DC volt, that is pretty high. So that is the cardioversion. And the third is permanent. They do not revert. That means they do not come back to the original sinus rhythm. Here, after cardioversion, they come back to sinus rhythm. And then they live happily. But when it is permanent, then your entire treatment, entire role, everything changes, right? Because your plan changes. Okay. So when we said atrial fibrillation, so we started with those symptoms, correct? And symptoms of what? The three classical symptoms: palpitation, dyspnea, right? Fatigue and dyspnea. Sinus rhythm. Sinus rhythm is nothing. It is like that PQRST. This is called a sinus rhythm. That is, Sharafat said from SA node, signal went to AV node, from AV node it went all the way to the ventricles. So that is what is called as the sinus rhythm. Normal rhythm of the heart is called as the sinus rhythm. So that is what really happens. This is such a condition. The heart tries to recover by itself. So sometimes after a few hours, you give the patient proper rest and you'll find that yes, he's becoming fine, right? Patient will say, now he is not feeling that heart is beating. Right? Breathlessness you will feel by his talk. Right? So they are the indication. Then when we'll be learning pharmacology, if this is your cardiac clinic, and then you tell the patient that don't do anything, just sit, relax, patient won't be fine. But at times, even if you give them the tablet of vitamin tablet, right, or you give just water injection, right, they feel, yes, I am getting treated. No, you are just handling a paroxysmal atrial fibrillation. But patient will feel, डॉक्टर साहब ने दवाई दी, I'll be fine. It has got, and it is a proven thing. It is called as the placebo effect. Placebo. In civil hospital, though, at night when your duty is there, right, patient will shout on the sister, like, doctor को बुलाओ. And they will जब हाथ जोड़, डॉक्टर साहब एक इंजेक्शन दे दो, मेरा पेन चला जाएगा, मैं आराम से सो सकता हूँ. You say okay, roll. Right. Just take the injection, right? Don't feel anything. Just put the needle in, and then you take out, and then you just rub and say, better? Arey sir, pain chala gaya. Yes, it happens. None of the injection it acts within 5 seconds. But yes, he will say, dekha, maine bola tha na sir. Yeah, it happens. Right? They are called as the placebo effect. Placebo. In pharmacology, I'll tell you so many such cases. Right? So interesting. Okay, so here it is. The palpitation, fatigue, and dyspnea. Right? That occurs when the heart rate is high. Right? Heart rate is high. But in some of the cases, patients are asymptomatic. So if the patient is asymptomatic, so why did that patient came to you? Because someone took the pulse, some MBBS doctor, right, who has taken the pulse and he found that this is irregular and that's why he has come to you, right? Go to the consultant. You took the pulse, you took the ECG, and immediately you found that this is irregular, but there are no clinical findings, right? There are no clinical findings. So that is what is called as the asymptomatic. So this is the range. This is how it is. So your ECG and pulse, they are most important in this case. Next month or so, maybe our timings are changing. Today only I had a discussion, but it is not yet finalized, but we'll let you know. It is somewhere in the morning. I think many of you must have been approached regarding the timing part. So we might be shifting to the morning hours. Tentatively, it is 8 a.m. Indian Standard Time, 8 a.m. So those who are into other countries, you might have to wake up a bit early. Okay, so coming back to this, so that's why ECG and pulse, these are two important areas which are to be taken care of. Now, what we are about to next, you are in Georgia. So next is, see, whenever we talk about cardiopathy or the cardiomyopathy, right? Cardiopathy or the cardiomyopathy. So here we are dealing with this is like chronic weakness, right? Chronic disease of the muscles of the heart, muscles of the heart. So here myo means muscle, pathy means there is disease, and cardio means heart. Heart gets weak. Heart muscles, they go wrong whenever there is untreated, right? This is important. Untreated rapid atrial fibrillation. Now, what's this? Today, while run, one of our friend, we measured her blood pressure. Her blood pressure was 176/106. We immediately told her, same patient, right? Same person, same friend. And then today I took the detailed history. And then she said that during her pregnancy, her blood pressure was high and it was not treated. Now, what has really happened is that it has been years, but now it has gone into, the heart has gone into this atrial fibrillation. So any of the stressful conditions, stress, for females, most important, pregnancy. There are some genetic causes also. But for females, during pregnancy, they insist that yes, there are her, she should be in good mood, right? She should be taken proper care of, cut down the salt, so many things. Why they say that whenever the female is pregnant, she should never be taken out for those junk food and fast food. No alcohol, because all these things, they are leading to this atrial fibrillation. And this is what is called as the tachycardia. Because heart rate increased, tachycardia induced cardiomyopathy. Because when the female is young, right, when she is pregnant, right, she is in her 20s or she is in her 30s. So at that point, things are, her heart is also in good condition, but it has sustained that damage. And then what really happens, it leads to decreased left ventricular ejection force. That is decreased. So this means her heart is now going towards systolic heart failure. You got the idea? Systolic heart failure. And this process is a very gradual process. It started with that pregnancy when the blood pressure was remaining so high. So because the baby is selfish, right, baby will say whatever, I need nutrition. So that's why the heart rate kept on increasing. Heart was taking load, and it led to damage to those muscles. As the age increased, now the heart is gradually becoming weak, and then all these things, they are manifesting fast. So it leads to, you find that why such a good runner and now becoming breathless, right? Why not recovering from full marathon even after 1 week? Why she's getting that fainting, right? Chalte as if, right? You take the pulse, and why do you get that irregular pulse? And when you take the ECG, you find that this is a case of fibrillation, asymptomatic fibrillation, right? This happened today. That's why I thought of discussing. And who was the culprit? The culprit was years back that particular doctor, right, who never treated that hypertension in that pregnancy. Nothing can be done, but this is what really happens. On to one more concept. This is SA node. This is AV node. AV node is it is a type of tissue, right? It is a tissue. In your 20s, right now, your SA nodes, they will be awesome, right? They will be so awesome. A small pulse, right? Small pulse comes, fatak, right? Immediately it will transfer it to the ventricles. Because tissue quality is so good. But as the age increases, that's why they say that aging, it is a process. It is a process when the tissue quality, tissue efficiency, use the word efficiency, it decreases. Right? So over here, what happens? That when the patient is young, right? When the patient is young, so in that case, you'll find that because their AV node is better, and such young patient, if he develops all these multiple foci, so more number of pulses, they will pass through the AV node, so there'll be more QRS complex, right? More QRS complexes. So that's why they will be having young patients, right? Both the cases of AFib, right? Young patient and old patient. But young patient will be having rapid heart rate. Right? He will be having a rapid heart rate. Correct? In case of older patients, AV node is now not transferring the things at such a good pace. Right? So what would happen? Slower heart rate. Right? So this is, whenever you see ECG, make a habit of watching that what's the age of the patient, because it is not written over there. So importance of age. Another thing, SA node is firing along with those multiple So this is the atrium. You'll find that in atrial fibrillation, as we said, that it will shoot. It will be more than 350. It goes up to 500 beats per minute. It can go that high. But only some of the signals, they will be passing through the ventricular region. So ventricular rate, you will find that cannot be 300 to 500. It will be much less. It will be about even half or even less than half, about 160, 180 beats per minute. Right? So this is what really happens. And why this? Because of refractory period. Refractory period of whom? Refractory period of unrepeating AV node. Cause one of the question. Right? Make sense? Right? So why atria is at 500 and ventricle is at 100? Because of this. Because in between there will be the AV node. And that AV node is acting as a barrier. And it has got refractory period. So during that phase, anything is spoken to AV node will say, I'm not listening. Right? So that's why one signal, no response. Second signal, no response. Third signal, and it goes. Right? So that's why this happens. Yeah. Another important concept, and that concept is, which you already know, preload. Preload. But why I'm telling you is, just one word I'll write, and I want you to say something on it. Some of the patients, they are called as the preload dependent. Preload dependent patient. What can you think of it? I don't want silent audience. Seriously. 25-30 लोग हैं. Say something. What is like, in which type of patient it is so important that they are preload तो अच्छा होना चाहिए. They have high heart rate. Okay. My question is, okay, athletes, good answer. Anything else? True. But athletes, they won't be patient. You know? Athletes are not patient. Are they good? Low blood pressure. Why maybe? Have faith in yourself. You're right. You're right. Very good, Aniket. Very good. Newborn baby. Because that chota bacha, usko to matlab, if the ventricle beating rate decreases, the pumping pressure decreases. Shabash. See, you guys don't understand your value and don't understand your intelligence. Seriously. जब तक नहीं बोला तब तक why no one was writing anything, and still so many people have not written, but something must be going into their brain, है ना? बोलो यार. Medical is not to be ratified. वो ratification वाले they are कुछ नहीं सब भूल जाते हैं. You remember this? मतलब for this ना, this why when I said this dance, or my teacher Makar sir, he said this thing. तो बेटा fibrillation और flutter समझना होगा. इतना सिंपल. कहते शादी में नाचे हो तो मतलब in our medical PG medical the class was of 220. तो मैं तो as if I always used to feel like sir मेरे से बात करें. मैं कहा हाँ sir. He said stand up. Right? So this is what really happens. मतलब he said कि yes, कि क्या हुआ? मैंने कहा सर ताली बजाई. कहते क्यों? कहते सर आपने बोला अब मैं जिंदगी में कभी नहीं भूलूंगा. तो this is what, and when you said this nagging dance, I was happy. Yeah, I could really visualize कि हाँ. So after decades, still I remember when he said, and then he was very happy. Shabash, this is the thing. I mean, the highest respect also, he was a person who gave me, because after completion of my post-graduation, he said, chalo, you come to anatomy department और अब तू मेरे बच्चों को पढ़ाएगा. And on that stage, right, when he said that he introduced me and he said that he was my student, but today I'm proud that he knows more than me. मैंने कहा sir नहीं, no. He said now you can call me Dr. Martin. मैंने कहा नहीं sir कभी नहीं. So it is like so humble was he, and these are his teachings. Many of the examples, they are like his examples. It's set in the mind. Okay, chalo. Coming back to our this. Thanks, Andy. Thanks. So preload dependent patient means कि उनके लिए preload is life and death. Now think of this. I'm drawing one figure and tell me which conditions this. Which condition is this? This is narrow. Which condition is this? This is left ventricle. Below. This is aorta. You know? This is narrow. कौन सा valve? That's right question. A question mark क्यों डालती है? अरे aorta है तो aortic stenosis, right? You are right. Aortic stenosis. Was confidence रखो, confidence, right? Say with confidence. होता क्या है कि when you doubt रखो ना अपने आप पे, तो then it is like you are a bit hesitant. Say with confidence. गलत हुए कोई बात नहीं. It's okay. Good picture देखा था. I could never guess कि यार काजोल was the murderer. Right? मैं तो दूसरा सबको सोच लिया तो उसके बाद के साला इतना नहीं सोचा. But then I never forget that movie. You know, your emotions are involved. हाँ अनिकेत seriously. See, basically we all are born smart. Right? Bluntly, we all are born smart. इसमें भी we always feel कि यार मैं तो जन्म से मैं तो डिटेक्टिव ही बनने के लिए पैदा हूँ. शर्लॉक होम्स की आत्मा ही मेरे अंदर है. When you are right, तो you feel कि हाँ यार this is like easier मेरे लिए. And when you are wrong, तो you feel कि साला I am so idiot कि इतना नहीं पता चला. But in both the cases, you remember that event very well because you took part in that. बाकी जिसने part नहीं लिया, for them it never got registered into your limbic system, into your emotional center. तो वो बात भूल जाती है. So medical is like, we really try to mimic the things when pathology पढ़ेंगे या when we will be learning medicine. तो when you try to mimic the things के हाँ as if कि मैं ये patient हूँ तो मुझे कैसा हो, right? Especially you must have noticed that in say अपना brachial plexus के time, right? So I used to do like hand like this, but even video में भी है because that's how the hand really goes. And if you really try to do that thing, so you will know that हाँ this is Erb's palsy. This is what really happened. These are the muscles which are important. You never forget. So this is, you are right, aortic stenosis, 100%. Right? So aortic stenosis means blood is, that the path is narrowed. So there would be less blood which will be going. So entire thing depends upon if this left ventricle should be fully loaded, properly loaded, then थोड़ा बहुत blood जाएगा. अब यहीं पे खाली है. तो एक तो scarcity, ऊपर से rationing, right? So this becomes a trouble. So that's why such patients, they are called as preload dependent. If there is left ventricular failure, right? The thing what is called as the stiff ventricle, that is called as stiff ventricle. So ventricle is unable to compress, right? So in such case, ventricle जो थोड़ा बहुत compress हो. So if the blood is properly filled, so more amount of blood will go. So these are the two very important conditions. One, the aortic stenosis, and second one is the stiff ventricle. They are what is called as the preload dependent patients. Right? Preload dependent patients. So technically speaking, many times you will be hearing from the cardiologist when they say there is loss of atrial kick. So atrial kick, right? It is called as the atrial kick. So when the atria, right? Imagine, atria ने लात मारी blood को and जा left ventricle में and आगे बढ़. So that kick, if it is gone, got it? It is the ventricle who is kicking the blood into the left ventricle, and if this atrial kick is lost, so then less amount of blood will be going all the way. What will it lead to? It will lead to two things. One, there would be the loss of cardiac output. Correct? Makes sense? Loss of cardiac output. And when there is less blood into the circulation, what will happen? Blood pressure will decrease. So there would be hypotension. Correct? There would be hypotension. And when such person is trying to run, there would be hypotension, right? And when such person will try to run, so the demand is increasing, cardiac output is less, person will faint. Correct? Hypoxia is what? Hypoxia is, yes, because of less blood. When less blood is reaching to the tissues, right? Especially when it is reaching to the brain, right? So that will start affecting so many other things. So this is what really can occur in fibrillation. Right? Now for the treatment part. As such, AFib is not dangerous. It is not dangerous. As compared to what can really happen because of AFib, it is more dangerous. Because of AFib, atrial fibrillation, let's say we are sitting into atria and from everywhere, right, signals they are coming. Now inside there is blood. So you are right hitting the blood from everywhere. So thus there would be formation of what is called as the thrombus, a blood clot, a thrombus formation, a clot formation. Clot is formed. Now that clot will remain into that atria, right? That cone. But if that clot breaks, a part of it breaks, and that is called as embolism. Embolism. Thrombus means clot. एक जगह पे बैठा हुआ. A part of it is broken and it starts going into the stream. And now the patient is like a time bomb. You can't say what can really happen. This embolus, right? It is called as, this process is called as embolism, and this is called as embolus. Embolus means released clot. Released clot. Now this clot is on journey. It moves. If it reaches to brain, what really happened to my aunt, right? To my auntie, it reached to middle meningeal artery, and from there it went to Broca's area, area 54. And this Broca's area that was devoid of blood supply. Everything was done, but still today her speech is affected. She is unable to speak properly, right? Because the Broca's area which is meant for the speech, right? So that is what is called as the aphasia. Aphasia. She has got the global aphasia. It means when she is trying to speak, the words are in her mind, but she is unable to pronounce it. She is not knowing how to speak. So in the initial days when her treatment, she was in US, so we used to say, I used to say, bolo, yaar Gujarati, to I said, bolo maru naam, right? Mera naam bolo, speak my name. So then she would say, right, and broken words. Gradually, say it happened like one of my students, her father was also having this, and say today after about 8 years he is quite fine now. So she has also become a cardiologist, right, and very senior. but she still remembers that yes sir 8 साल पहले क्या हुआ था. Yes, but she father recovered. So here also we are hopeful that, and she is doing quite good. But these are called as the stroke. Stroke. In stroke, which part of the brain would be affected? No one knows. Right? So that's why when it happens to these areas, it happened. What if it reaches to the cerebrum? When it reaches to the cerebrum, then half of the body is paralyzed. Right? When it reaches to some other area, right? Say for example, if it reaches to cerebellum, when it reaches to say thalamus, memory loss, right? Person suddenly starts forgetting everything. So that is what is called as a stroke, which is like a huge topic in itself, because we'll be deciphering every part of the brain individually, that what happens if it goes wrong over there. What if it reaches to the liver? Right? Liver. So that part of the liver, now it is not getting blood. So it leads to liver infarct. A portion of the liver stops functioning. Correct? This, which is like most dangerous. I suffered from second wave of COVID and treated myself. This is the thing which was suspected. I went for CT scan and found that my middle lobe was totally collapsed. Totally collapsed. And because there was a threat of, say, when it goes to lungs, right? The problem is pulmonary embolism. Pulmonary embolism. Pulmonary embolism is when this clot, it goes into the pulmonary system and it blocks it. When it blocks, it is immediate death. So that's why I'm just writing the name. It is called as Apixaban. Pretty costly drug, but it was mandatory. Took it for almost 1.5 months. Right? 1.5 months I was taking it. And then it has to be gradually tapered. So this is that. But there are side effects, because this is a very strong anticoagulant. Now you can make the correlation, correct? Anticoagulant. It is anticoagulant. It won't let the blood clot. That's what we want. That this clot should not be formed, because if it forms and if it lands into this space, right, then game is over. So that's why very meticulously, right, Apixaban I was taking, right, time to time. Multiple alarms were set. Let's say if it goes into the spleen, so then it will lead to splenic infarct. Right? Splenic infarction. If it goes into gut, right, now gut, right. So over there are mesenteric vessels, and those mesenteric vessels, it leads to mesenteric ischemia. The part of the gut starts dying, so you have to surgically operate it and remove that portion. And imagine how complicated it becomes. That is the reason that in such cases you need to give anticoagulant. So see, you have just watched an ECG and then you said you start taking this medicine. People at times don't understand that there is so much going beyond the ECG, that normal ECG. I mean, patients related, you'll see that thing. They will sometimes say, एक ECG देखा और कहा ये दवाई चालू कर दो, इतनी दवाई, इतनी महंगी दवाई. They are महंगी, but their importance is, what if any of the organ goes wrong, right? So this is what really happens. Next important thing is, no doubt, we'll be discussing, I'm not writing it, not to make things more complicated, but you know, at least see this part. This wall, right? If this wall is affected, this wall is narrow. So this is what condition? What condition? This wall is narrow. That's right. Why only one person is writing? मस्त फटाफट मतलब mitral stenosis. Seriously, sorry यार थोड़ा खांसी हो गई है. यूएसएमएलई बैच तुमने हालत खराब कर दिया आप लोगों की. मतलब in 10 seconds if you don't reply ना, मतलब द मोमेंट क्वेश्चन इज आत धड़ 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 धड़, मतलब 25 लोग हैं तो 25 आंसर. हाँ चलो नेटवर्क इशू है. अभी दे रहे हैं. I'll let you know. हाँ, so coming back to this is mitral stenosis. Mitral stenosis, it can be associated with rheumatoid disease or without rheumatoid disease. A key point when you come across that ventricular, I mean, someone is having mitral stenosis. Now, how to identify? By the way, that instrument is coming this week, which I said that then I'll be able to, if I auscultate and I'll be able to tell you that now listen to this heart rate, right? So this is like when I'll say this is first heart sound, this second heart sound. So it will be, there will be the graphical display along with the sound and everything will be live, right? That instrument, that is coming from IIT Bangalore. It is a very special device. Okay. So whenever, you'll be hearing in your earphones. Exactly. At that point, I might tell you that instead of say normal speaker, if you keep the your earphones or the headphones, you'll be able to understand it much better. Right? But I'll let you know. It is expected on Thursday. This Thursday. Today only I got the call. So in that, when you auscultate and you find that person is having mitral stenosis, right, and it is with rheumatic disease. So in such case, you take the ECG and you find he is having AFib also. And this is rheumatic. So this is mitral stenosis, rheumatic disease, and atrial fibrillation. Chances of thrombus very high. I mean, even if the patient is fine, start with the anticoagulants. Just this much, if you can remember, is fine. If not, no problem. Because combination of this mitral stenosis, आप stethoscope रखेंगे. It is stethoscope रखेंगे and you will come to know that what it is. So that was about this atrial fibrillation. So any of the conditions, right? They always keep on damaging. Say commonly associated that if someone is having high blood pressure, right? Hyperthyroidism, or coronary artery disease, right? Coronary artery disease, 1 block, 2 block, they are very much prone for these things. That's why at times, say, a very simple सी चीज, many times in blood report, you must have seen T3, T4, TSH, right? Thyroid function test. Watch for TSH. Watch for TSH. Its normal range, it should be 0.5 to 4. Right? 0.5 to 4. Now, this is very interesting. When it is less, and how much less? Less than 0.4. It is less than 0.4. So then it is hyperthyroidism. When it is more, right? When it is more than 4, So that means thyroid is hypothyroidism. Logic? Plus simple. TSH is thyroid stimulating hormone. Thyroid बैठा है, right? How many times, right? You go and ye जाग काम कर, right? And he said, So that means TSH has to say so many times, so its value has increased to 4. तो भी thyroid सोया पड़ा है. And when it comes to thyroid, TSH ने just बोला thyroid काम कर, हाँ करते हैं ना, धमाधम काम शुरू किया. That means when the TSH, slight release of TSH and thyroid is working. So this is an important thing to know about, that TSH when low, it is hyperthyroidism. TSH when high, it is hypothyroidism. So think it like thyroid is sleeping and then TSH is going and jago bhai. This 0.63. 0.63 is within normal range. It's okay. Not to worry. Another important thing in this case, the thing what is called as the triggers. What are the triggers? Stress. Stress is a big trigger, especially during exam or during Viva. Right? When you will be having Viva, I'll take one lecture on, one discussion on, because at that point I might tell that आप सब अपने video भी on कर. It is in that lecture. That is how to face any of the interviews and how to smartly tackle any of the interviews, even if you are not knowing the answer. So how to keep your head cool. So this stress, that is a very dangerous thing. Second, what is called as the binge drinking. Binge drinking. Right now, I'll not be going into extreme details, but for some of the patients, it is like they take alcohol and their heart rate starts increasing. And when the heart rate starts increasing, it is at times AFib, atrial fibrillation. In any of the conditions in which there is increased adrenaline, catecholamines, right? Catecholamines. So whether it is any sort of surgery, whether it is any sort of big pain, right, some injury, or it is any sort of infection. So all these things, they lead to rise of this, or emotional surge, so they can develop atrial fibrillation. And that atrial fibrillation is not, if it is not coming under control, so then you need to handle it. So that is what is called as the treatment, how to handle it. What are the things which you have to do? Right? In just one simple table, I'll explain this. Your responsibility is 1, heart rate. Heart rate should come down. Right? It should come down less than 110 beats per minute, because this is a case of AFib, what you are handling. Atrial fibrillation, heart rate is going skyrocket. So first thing is this, what you have to do. So when you decrease the heart rate, I'll just fast forward. Here it is. This is before. This is after. What's the difference? If I say that what are the conditions you are watching, you will immediately say it over here that this is atrial fibrillation, because there are no P waves and the difference between QRS is variable. Same thing is over here, correct? The line, this is wavy, and the distance between QRS over here, this is 3 big square, and over here it is 1, 2, 3, 4, almost 4.5. 4.5. Yes. So without my much saying, you will say both the cases, they are of atrial fibrillation. But one thing is very clear, that this is decreased heart rate. Correct. Decreased heart rate. Heart rate is less as compared to this same patient. This is what was done as a first line of defense. First line of defense is that you decrease the heart rate. And how to decrease it? one calcium channel blocker. Now here comes our physiology, because calcium was needed. Calcium was needed for formation of that protein. You give less calcium. If you give less calcium, then it won't get the chance to contract. Right? So the entire process would be elongated. So that's it. It is decreased. Second, maybe beta blocker, right? Beta blocker, beta 1. Or there is another drug which is called as digoxin. What digoxin will do? You'll understand in 1 second. Stimulates parasympathetic system. Done, right? Clear? So here you have decreased the heart rate. Patient will feel comfortable. Patient will feel better. Right? It is not the treatment, but it is much better over here, where patient has started feeling better. So patient feels better. The second thing what you will do is, you need to get the heart rhythm back. Heart rhythm back, right? Which rhythm? Sinus rhythm. We want sinus rhythm. And for sinus rhythm, the restoration of sinus rhythm, we need to go for cardioversion. I'll show you that defibrillator. And third, what we already discussed, coagulant. Because there are chances that there will be formation of thrombus, right? Thrombus formation. So we need to cut this out, because this is the most dangerous. So many complications they can really occur because of the thrombus formation. Because as we discussed, it gets dislodged and it goes, and it can lead to so many complications. Right? So that is one. This is the black page. So this is one where our purpose is rate control. Rate control. This is when our purpose was sinus rhythm. Right? Before saving this file, I'll remove those blank pages from it. So sinus rhythm, maintenance of sinus rhythm. So we want that sinus rhythm. So how did we do that? It is called as the cardioversion. Cardioversion. DC current is given, right? And you see that this is AFib and this is a normal sinus rhythm. Correct? This is a normal sinus rhythm which has come up. Even we can see the P wave also very properly. This is what is called as the defib or the D. Thrombus formation is rare or occurs mostly. Well, chances of thrombus formation is very high. Very high. And if you really want to say talk in detail about it, so that is what is called as, that would be a pure medicine point, but don't worry. As you have asked, we'll talk about it. It is called as the CHAD score. CHAD score. I'll just talk about it. It's a good question, so give me a minute. So this is what is called as the defibrillator, right? It is for cardioversion. So here, once this is charged, these are those electrodes. Once they are charged, gel is applied, and then this such high current is applied to the patient. Now this is such high current that when it goes, right, it literally resets, right, all myocytes, right? They are depolarized, right, and everything comes. It is like resetting the system. So sinus nodes, they all then once again they start their new cycle. And it is such a large current goes, so everyone is reset, and then once again they start with the SNO. So that's how it really goes. But its importance is, in such case, in case of AFib, right, you must be watching that there is that ECG is parallel ECG, right? A strip is also coming up, strip also comes out, and that digitally also it comes out. In case of AFib, it's an art. You need to anesthetize the patient. So anesthesia is given to the patient, and then it is what is called as the synchronized cardioversion. Synchronized cardioversion means when that current should go when there is QRS complex at the time of QRS. So when the ventricles they were out, and at that point you are giving large amount of current, everything is reset. Not to be given, right? So this, no one can give this thing manually. So that's why there are settings. So automatically the QRS complex, the moment it is detected, right, the current fires. So you have to press, and you have to press this red button, right? And at QRS it will automatically fire. Right? It should not fire at T wave, because if it fires at T wave, it will lead to ventricular depolarization. A large amount of current will be going into the ventricles, right? And the ventricles they can go wrong. They can collapse. Right? So it can lead to ventricular depolarization, which we really don't want. So this is an automatic system, but we should know, because these are the features of this machine. Charging clear heard in Netflix series. Sahi baat hai. So this is what is called as the electrical cardioversion. There is another version also, which is called as the drugs or the chemical, but it is not used much because there are so many side effects. Right? So this is what is called as the chemical. And chemical you don't have to give. This is most effective. In chemical, you don't have to give anesthesia. That is the only advantage. Otherwise, you are giving class 3 anti-arrhythmic drugs. Say ibuprofen, that is the commonest drug which is used, but this is much safer, and the results are immediate. Now, what the question is, which was very nice question, which was asked, thrombus formation. So, as said, the topic is open. Right? There are some surgical things and etc., but I think I'll take it next time. Next time, I'm also thinking of teaching you about bundle branch blocks. Right? Left bundle branch block, right bundle branch block, and then we'll be talking about the ventricles and the failure. So at that point, if the time permits, we'll take the surgical part. So yeah, thrombus, myocardial infarction. Next time. Myocardial infarction next time. Cascade mechanism, it was also in 12th standard. Ruchita, you are talking about this blood clotting, coagulation. Yes, it must be there into the 12th standard. That's right. But over here, you'll be learning it in super detail. You'll relish it. So, regarding the thrombus, now see, you detected from ECG that it is AFib, and it is crucial. You said, "Chalo, take the patient to OT, and we are going for cardioversion," right? And we applied, and the blunder which we did, it was the thrombus which was there. It got dislodged, and now that embolus is into the circulation. Because such heavy current, so the whole heart contracted once, right? And that embolus, it got dislodged. How bad would you feel when the patient, after some time, you find that patients, when he's drinking water, the water is dribbling from one side, his entire face is getting distorted, his one hand is going like this. How bad would you feel? And what if it is pulmonary embolism? Seconds and game over. Patient would die on the spot. Right? Pulmonary embolism, it is so dangerous. If the lung is collapsed, then it is that risky. When during that COVID, I never told anyone that this is the danger which can lead to pulmonary embolism. I never told anyone, no family members, no friends, nothing, no one, because it is a very, very painful thing for even others. So this is, so what you have to do. Remember this part. Though now what you are learning is pure medicine, but I feel like that makes subject more interesting, because then you know the importance. Otherwise, so what? AFib is just those finding it on ECG and 2-3 important those sign symptoms. That's enough. But for thrombus, remember this: 48 hours. Thrombus formation, it occurs after 48 hours. 2 days they are needed. So if you know the patient has developed it now, use the cardioversion safely. Nothing would happen. So before 48 hours, right? Before 48 hours, it's safe. Cardioversion is safe because it will take 2 days. But what if after 48 hours, don't take chance. After 48 hours, cardioversion, it is dangerous. देना ही पड़े, situation is bad. So then hold it. The solution is after 48 hours, if you then immediately start top quality anticoagulants like apixaban, right? Start it. Give it for 3 weeks. Within 3 weeks, 21 days, right? It will cover up. So even if there is any clot, right? So everything will be dissolved. And then, because it is a very critical case, so you will be doing this. You remember, right? That if we draw the heart like this, which structure is over here? This is left atrium. This is right ventricle. This is left ventricle. This is right atrium. Which structure is this? Shabash, very good. This is the speed at which the response should come. Esophagus. Correct. So esophagus. Thrombus is always into left atrium. So what you'll do is you'll do a transesophageal echocardiogram, right? Transesophageal. So you let the probe go in, and from there you do the echocardiography of the left atrium. So this is what is called as the transesophageal echocardiography. So when both these things, you have given the anticoagulants for 3 weeks, and then you do the transesophageal echocardiogram, things are good, right? And still the patient has not recovered from the atrial fibrillation, go ahead. Now you are safe to do cardioversion. Right? And that's how things would go. When we'll be studying pharmacology, we'll be doing in depth about both these things. That is step 1. That is when you have to go for the rate control, right? Rate control. So which medicines will be. Second, when you have to go for the rhythm control. Rhythm control means in that case there are anti-arrhythmic drugs, right? There are many anti-arrhythmic drugs. Yeah, these are the treatments, right? These are the treatments. And the third is when you have to give the anticoagulant, right? Anticoagulants. So which anticoagulant you have to give, because there are so many different types of anticoagulants. Especially say rivaroxaban or apixaban, these are all factor 10 inhibitor. But there are others also. And if everything is fine, so then you can even go for simple aspirin also. But there is a complete plan, right? So this is when you are giving those calcium channel blockers and the beta blockers, right? Digoxin. Rhythm control, that is when you'll be giving anti-arrhythmic drugs, right? In which there are 4 classes: class 1, class 2, class 3, and class 4, which you'll be learning in pharmacology. And in anticoagulants, again, there are various types of anticoagulants. That is where they will be really acting, right? And at times you have to really see the price also. So for example, warfarin, that is pretty cheap, right? And this Epixaben, that every tablet would cost in 3 digits. Right? So they are costly. I mean, this much small bottle will cost you about 4,000 rupees. Right? It's 30 tablets. So while warfarin is costing 2 rupees, but depending upon the severity, you need to go for it. So that is how the treatment really goes. And the most advanced thing, right? Most advanced thing, that is what is called as the CHADS score, CHADS. Right? There is a newer version of this also, but this is just for the explanation. That is, when do you say that all these things should really be started? This is what is called as the CHADS score. When there is congestive heart failure, you watch the feet of the patient. Are the foot swollen? That means there is congestive heart failure, right? 1 point. That is C. Second, H. H is hypertension. Check the blood pressure. Blood pressure is high, 1 point. This is age, right? Age. If the age is more than 75 years, now there is a newer version of this CHADS score, right? Which tells if the age is between 65 to 75, to then 1 point, and if it is more than 75, to then 2 points. But right now we are just understanding this. D, diabetes. Patient is diabetic. 1 point. And if the patient has developed stroke, 2 points. Make a total. If the score is more than or equal to 2, immediately start anticoagulants, because chances of thrombus formation are very high. Right? If the score is 0 to 1, so then you start with aspirin. Aspirin is also anticoagulant, but it is very, very minor form. Right? So I think you got your answer. Right? That thrombus formation, it depends upon all these factors. Not only the atrial fibrillation, but it also depends upon the pre-existing conditions, some associated conditions, right? And the age. So that's how things really go. Actually, I'm fast forwarding it to this. Let's spend 2 minutes on atrial flutter, right? The synchronized one. Right? Atrial flutter. So if the fibrillation was like random spots, right? Over here, in case of atrial flutter, it develops a circuit which is called as the reentrant circuit. Reentrant circuit. Usually this occurs after myocardial infarction, or when some of the tissues are damaged. So then the current goes round and round and round. Re-entry, right? We understood that the mechanism of re-entry. That this is normal. Sorry. Whenever there is any block, so then over here it stops. This is the normal one. Then it proceeds over here, and then it goes round and round and round. This is what is called as the reentrant circuit. So every time it goes round, it stimulates the AV node. Now, because it is not moving at a very high pace, right? So that's why AV node would be stimulated, and it would be sending it further. But because it is synchronized way round, again and again and again, so it will lead to what is called as the sawtooth pattern. Sawtooth pattern. That means impulse, 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 and then QRS, impulse, impulse, impulse. This is what is called as the sawtooth pattern. Right? And you will find that this is seen in every lead. Every lead, right? And crystal clear, seen in every lead. 1, 2, 3, AVR, 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 1, 2, 3, 6. So here it is. See how precisely, see, whether it is AVR, AVL, AVF, anyone, right? Say V1, it is. Here it is. Here it is. Right? When you see such spikes, when you see such spikes, they are called as the sawtooth pattern. You will be able to see this thing in every lead. See, this is a rhythm string, classical pattern, right? So that is what is called as the sawtooth pattern. This thing is less dangerous as compared to atrial fibrillation. This is what is called as the atrial flutter. Atrial flutter. Sign symptoms, you find that they are pretty similar, and it is the ECG, right, which will give you the diagnosis. So sign symptoms similar to AFib. So same, yeah, palpitation, dyspnea, and fatigue. So once you take the ECG, then you take a call. But yes, here also you will always be atrial flutter. Also, you will always be going for anticoagulants, right, based on the stroke risk, because that is a lifesaver. So I think we stop at this point. So really appreciate 21 people. So thank you so much. Early कहाँ 7 बजे? I mean, this is such a topic. मतलब इसके पर तो मतलब we can talk for hours and hours, because then advanced chat score, then here there it would be 5 p.m. सही बात है. नियति कितने बजे college? When are you having? What are your college timings? हाँ दुर्गेश, ये these are the notes, right? You don't have that link with you. If not, just send a mail to me at till you are Mbbs, right? I'll send you the link. All the notes are lying over there. I'll put this thing right now. Okay, Vietnam time 7:45. No, what I'm asking is, Niyati, if we are starting at 8 a.m. in the morning, will it be convenient or no? Oh, okay. So as per your college starts at what time? What time we wrote? 7:45. Okay. So we'll let you know how to manage. We'll definitely plan for other batches. Sure. Okay. So I'm putting this file into that shared folder. Take care. Bindas karo na mail yaar. Bindas, absolutely. No problem. 10 बजे तो मेरे दोस्त मैं सो जाता हूँ, because I have to wake up at sharp 4 o'clock in the morning. By the way, those who are in Mumbai, right? I got my registration confirmation from Tata Mumbai authorities. So coming on 18th of February, and I'll be there in Mumbai till 18 को आएंगे. 19th is the race, and I'll be over there for 20 and 21st शाम को I'll be returning. So very eventful months. Next December May there is one race which is of 21k. There is another race which is of 32k. Then Tata Mumbai which is of 42 kilometer, and in March there is another race which is of 75 kilometers. We'll definitely plan. Those who are in Mumbai, we'll definitely plan to meet. I'll come to office. Okay, so thanks a lot and take care. Wish you a very happy weekend. See you soon.